Good afternoon and welcome to Enterprise System Decommissioning and the Complexities of Managing Down the Portfolio, a Health System CIO Media Inc. production sponsored by Harmony Healthcare IT. Just a little housekeeping. My name is Anthony Guerra. I'm the Editor-in-Chief of Health System CIO and I'll be your moderator today. We're looking forward to some audience participation. You can send in your questions or comments at any time in the Q&A box. We'll take those later in the program. And we're going to run a little one-question poll later that you can participate in, and we'll have our panelists guess at the results. Nice way to see your screen today. First thing you want to do is in the top center, get in its side-by-side mode. Then you can adjust the divider to get the slides and the video boxes the size you want. And it should say speaker view in the top right-hand corner. Just so you see how we're going to spend our time today, we're going to go about, I'd say, 35-40 minutes with our main panel discussion featuring Ed Duryee, Director of Information Systems, Columbus Regional Healthcare System, Kory Hudson, Director of Information Systems with Singing River Health System, Tom Branigan, Senior Project Manager with Spectrum Health, and Jim Hammer, VP of Operations and Product Development with Harmony Healthcare IT. And then we will have our audience Q&A. So again, send those in as they occur to you. So let's jump right into our featured discussion. And I'm going to start with you, Ed. Can you give me an overview of your organization and your role?
Yeah, thanks, Anthony. Columbus Regional is a small to mid-size healthcare system, Whiteville, North Carolina, near Wilmington. We're 150 beds. We are independent and managed by Atrium Health out of Charlotte. And I've been there just about a year. And prior to that, I was a consultant there and led the Cerner implementation. And before that, I've been on the consulting side with some of the larger firms. And before that, CIO role at a couple of different organizations.
A well-rounded body of experience. So looking to hearing from Ed today. Kory?
Yes, Kory Hudson, here, Director of IT here at Singing River Health System. I've been here for 12 years. I've been in my current role since 2014, and certainly been through many applications and managed hundreds of solutions. So thank you for having me.
Lots of experience there too. Tom?
Yeah, I'm Tom Branigan. I'm a Senior Project Manager for Application Archiving at Spectrum Health. Spectrum is the largest health system on the west side of Michigan. We have over 12 hospitals and dozens of practices that make up our system. I've been working on application archiving for Spectrum for over 5 years now. Spectrum started their archiving initiative back in late 2014. So since that time, we've archived over 80 different clinical applications. So yeah, happy to be here. Thanks.
Excellent. Thank you, Tom. Jim?
Yeah, thanks, Anthony. I'm Jim Hammer. I'm the Vice President of Operations and Product Development for Harmony Healthcare IT. That basically means I get to lead a great team of individuals who solve problems for the gentlemen like we have on the panelists today. Harmony Healthcare IT has been in the market for 14 years as a leading health data management organization. What that really means is anything healthcare data related from migration, archival, and decommissioning, which we'll be talking about today, long-term data storage, interoperability, and analytics, to name a few, really are services and products that we offer. We're also, from the last time we talked, we're very honored to, we've been named first in class this year for the archivable space, as well as first for the last 2 years in the data extraction and migration category from a company called Black Book. So definitely honored to be here today. I look forward to talking to the panelists as well.
Excellent. All right, Kory, we're going to start with you on this question. With many organizations tasked with reducing IT spending, is reducing your application portfolio one of the ways you plan to achieve cost savings or have done so in the past?
Definitely. Obviously, finding the right archive solution has been probably the most challenging piece to that. So, when you have all these silos of information, and you have to continue to pay some level of support for some of those solutions, then the ultimate strategy is to, try to offload that data onto a single archiving solution so that you no longer have to pay for support, because you're obviously obligated to save the data and retain it for a number of years. So the last 5 years or so, we've been slowly, again, because budgets are also capped, and you can't just archive everything all at once. You have to slowly budget for those, because you have other needs as well in the budgeting process. And so it's taken us some time, but slowly we've been dwindling down. I think we're coming to an end here, but it's taken that long to do so. But I mean, it's a huge cost saver, and it's great that there are solutions out there to aggregate all the data into a single archive.
Right, right. So it's an interesting point. Even though it's going to save you money, it does cost some money to get it done. So you can't do it all at once. You have to budget to save the money, right?
Right.
Interesting. Tom?
To piggyback on that, that's definitely a concern. We've found that, our break even for the cost to archive, it sometimes takes 3 to 4 years before we're actually seeing the cost savings. So it's a hard sell sometimes when you think about the initial upfront cost, but when you consider that, a lot of these applications contain data that has to be retained for over 20 years. Our record retention policy has, most clinical data has a 20-year life that we have to keep it. And luckily on our side, though, we've had a leadership committee that's committed to this initiative, and I think that makes a big difference. They understand the initial upfront cost, but they can see the long-term benefits from doing this work. And like I said, after 3 or 4 years, sometimes even less, that's when the savings really starts to come in, and sometimes it's quite significant.
So the key is just articulating that you said to leadership. People have to understand.
The key is to have a leadership team, that is forward thinking and on board with, the benefits of what this, brings.
Very good. Ed?
I'd say the theme we're all saying is sometimes you have to spend money to save money, and
Right.
you need to do a ROI, which looks at the long term.
Right. Spend money to make money. That makes sense. That makes a lot of sense. Jim, I'm going to go with you on the next question. What kind of cost savings have you seen from reducing your customers' application portfolio and archiving legacy data? So can you set an expectation, for the conversation and frame it up as to what you've seen in terms of spend versus ROI, making that argument, getting leadership on board, or the argument leadership needs to make to get this done?
Sure. Yeah, I think the gentlemen here have kind of outlined the hard tangible items, such as maintenance costs, renewals of that. That's straight ahead. Usually there's a infrastructure spend savings as well. So a lot of our customers are now going and asking for hosting, where that wasn't the case several years ago. But even in an on-prem situation, reduction of infrastructure costs of the data center as an example, as you shut down some of those legacy servers, certainly brings cost savings directly there. Then you go into some of the soft cost savings. So things like who still can support the application if it's running 5, 10, 15 years past a demarcation line to your new product, let's say Cerner or Epic as an example, it's harder to find folks to either train and or support as those resources are kind of transitioned into new roles. As well as we talked a little bit about infrastructure, but the security and the stability of those things. So there's a compliance and risk aversion cost savings, meaning, you know, if a server goes down and it's not been decommissioned in the archive, you don't have access to that data any longer. So patient care can be affected, as well as just, you know, in case of subpoena or a lawsuit, that data is no longer, you know, e-discoverable as an example. So a couple cost savings, like I said, hard and soft.
Yeah, so there's lots of reasons that you might want to go ahead and archive some of this stuff. Next question, let's go with
Anthony?
Tom. Yeah.
Yeah, if I could jump in on the
Sure.
cost savings. A lot of the discussion we'll have is on clinical systems, master patient index, visit history. And in our situation, the cost savings really came from converting the active AR. And our partners at Atrium Health advised us that the days of just taking your AR, running it down in maybe 6 or 12 months, and then sending it out to an agency, those days are over because of the Medicare rebilling and the audits and the takebacks, adjustments, et cetera, where you could be doing that for years in the future. So in our case, we took our active AR and converted it over into essentially an AR system in the archive, a special application. So that was a significant cost savings of no longer running that legacy AR system, and just archiving to a static was not an option for us, at least in our region, because of years down the line of all this rebilling and audit activity. So things have changed, at least in our part of the country.
Very good. Thanks. Thanks for that additional point, Ed. Okay, next question. We're going to start with Tom on this. Why do application portfolios get bloated, and how can it be stopped? Any thoughts there?
Well, my health system may be unique, but it seems like we're bringing on new hospitals, we're entering in new partnerships with other health systems and new practices almost daily, it seems like. So that is the main, cause of how our application portfolios get way out of whack, and how we find ourselves with, several applications that are doing the same thing. So when we do an integration of a new practice or a new hospital, we have, teams that will go through what applications we are bringing on board with this practice, and whether or not it's a duplicate of what we already have as our standard. So then we find ourselves with these applications that are no longer needed, and that's why we need to do something with that data. But I would say that's our number one cause of application bloat, and it just seems like a lot of times practices just like what they've always used, and they're hesitant to move to something different. So you get some pushback sometimes, but for the most part, it's not difficult to get applications moved over to our standard.
Tom, do you know if those evaluations and those conversations, are they ever happening pre-acquisition, where that's part of the due diligence?
Yeah, 100%. And so that's what, we have an integration and migration team that works with the practice, because another thing you have to think about is who actually owns the data from these applications. If a practice comes on board with your health system, do they retain that data? Are they responsible for that going forward? Or does that data now become owned by the health system. So those questions need to be answered. And with answers to those questions, you kind of figure out what you're going to do with these legacy applications.
Very good. Ed?
Yeah, and also on the hospital side, even though we're a smaller organization, we did have a fair number of, I'll call them islands of automation of niche systems. And sometimes if a department director and VP make a compelling case, they can fight for and get support for keeping their niche application, at least for a while. So that's one way that the portfolios get bloated and you still have this long list. So really back to the ROI, it was mentioned earlier, kind of one central committee that approves or disapproves standalone systems. So that's important to do that centrally.
Very good. Kory?
Yeah, I mean, I would firmly agree with what the gentlemen are talking about here. I mean, ultimately, you need an overall organizational strategic plan. And, if you allow each department operational leader to kind of go their own path or go their own way, then you end up with all these disparate systems. And so ultimately what then happens is you end up with leaders or who eventually kind of get on the same page with everybody, and we're developing a strategic plan and we're trying to consolidate systems like, enterprise imaging or, certainly an EHR. But ultimately then when you end up with all these different solutions that you have to archive that information that's being stored. So if there's no clear strategic plan for the organization, I think that could also lead to bloating, as you put it.
Kory, what do you see as the IT leader, CIO, whatever the title may be? What do you see as your responsibility in making sure leadership understands the implications of bloat and retaining niche systems based on user preference? So it's easy for a high-powered physician to go into a CEO's office and say they want to keep using what they're using, and they bring in a lot of revenue. So is it your job then to say, okay, here's the downstream effect of that. If you're going to allow this, here's what it means, and you decide. I'm just the guy to enable. Is that sort of how you see it?
Definitely, and I think it depends on how savvy your other operational leaders are in the organization. If you have a CEO who's kind of focused on technology and innovation, then the argument is really easy. If you don't have that kind of leadership, then it's your job to communicate the pitfalls or the hurdles and the obstacles. And so communicating that and kind of pulling everybody together, not just handling them, as they snipe their way into, into your domain, I think is key. So.
Very good. All right, next question, Jim, we're going to go with you on this. Talk about application portfolio management. What are some of the techniques or principles by which the problem can be approached? So we know we don't want bloat. We know we don't want redundancy. Some of that's easy, right? Redundancy is redundancy. But what are some of the more subtle things you're looking for here as you get your inventory in line, you figure out what you have, and you decide how do you come up with a plan to reduce that? How do you figure out what's extraneous and what you can lose?
Sure. Yeah. Good question, Anthony. So primarily, most of our customers, as we engage, have a solution, something like ServiceNow as an example, something that's maintaining a master inventory of their system. A little bit more difficult in some of the folks that have recent acquisitions and they're trying to get their hands around kind of what that portfolio looks like, but kind of starts in the same place. And in some cases, we'll help with that kind of in this consulting engagement up front if there's difficulty there. But usually what happens is we'll work together to start building that list. And the things that are obvious, maintenance costs. So from a cost perspective, renewal dates of those applications for maintenance contracts. And again, a core key compliance and governance teams really important, which I think everybody's mentioned on this call, and with kind of responsibilities that they have as a takeaway. Example that would be certainly certain contracts have large dollar amounts tied to them. They may have today annual renewal dates as an example, but certainly as folks are leaving those applications, negotiation can happen, and those can often be brought down into a quarterly or in some cases a monthly contract renewal. So depending on when systems come offline, those costs can again be minimized against a larger renewal period, if you will. Again, same kind of thing we talked about earlier, risks, what risk might be involved in a certain application that might bring it to the top of the list as an example. So maybe the cost driver isn't the key. Maybe, we've had some really unstable environments as an example, and downtime, which, scares individuals. Maybe that's a first item on that portfolio list. And again, so those drivers typically are plotted out on, a solution. We happen to have an application inventory application that we've developed to try to make that situation easier as well. For having to deal with spreadsheets as an example around that, but that's usually the approach, at least at the onset, that's used. And then like Tom mentioned, again, with acquisition, usually we'll help with a story or playbook of as those items come on. Again, we typically know what we're going to archive based on past, policy and procedure and compliance and governance. So we can usually attack that pretty straightforward in terms of the requirements as we go system by system down the list.
Very good. Thank you for that, Jim. Next question, we're going to go with Ed first on this. What types of conversations, relationships, and committees need to be formed so you can get buy-in from stakeholders as you go through this process? What's the CIO's role and IT's role in general to lead, to support, or both?
Yeah, and one thing to note is that a lot of organizations will put governance in place as they go through a system implementation. And then what to do with the legacy data sometimes is run through those committees, but other times, since they're so focused on a live date, it doesn't get the attention that it needs, and it becomes kind of a supporting project, which then may or may not go through that governance. So that's an important point up front with your governance committees, is to decide the legacy data, the conversion, et cetera. Is that a function of the governance, or will it be a separate committee process?
Very good. Kory?
Yeah, I mean, it's important to communicate. One of our core values is communication is key, and certainly it's every leader's role to pull folks together and kind of strategize on what's needed for the organization. I think in this day and age, IT's role is paramount. You're not just an IT shop. You're not just a support department. I think IT's role now is kind of reached the pinnacle where they need to lead, and organizations are growing, they're merging, and with all the regulation and compliance that's out there, it's often my job now to find solutions for other folks and to think ahead of maybe even what our operational leaders are wanting to do, and kind of put solutions in front of them before they even realize they need it. So.
Well, yeah, that's always been an interesting issue with IT leaders, is that are you there to support and to sort of take orders, or are you there to lead? And we heard a million times in the past with implementations, you can't lead, you can't be the one picking the system, which is a little different than leading, right? I mean, there's some subtleties in there. It's not just black and white. You either lead or don't. You either lead or support. Kory, any more thoughts there? Because that's always been an issue to me that was a little gray.
Yeah, I mean, I think, the health IT leader today is not just, kind of an IT geek, right? They understand the landscape or should understand the landscape of healthcare. I think I understand a lot of, I don't know how to give a shot or take blood or, administer a med, but I can tell you I understand the workflows that go on within healthcare. And I understand all the technology that we've put in hospitals and clinics, and to understand kind of the landscape is integral to my job. And so if I'm not providing solutions or attempting to before someone's actually asking for them, then I don't know that I'm doing my job to make sure I understand what the healthcare landscape is all about. So yeah, I mean, IT leaders should be taking kind of an active role and not a take orders role, like you put it.
Right. Very good. Tom?
On our side, we have what we call our record retention steering committee. That committee meets monthly, and it's made up of legal, compliance, HIM, IT, the whole shebang. So we have everyone represented in that committee. And one of the roles of that committee is to review these, projects that come across my desk and determine whether or not, it's in the best interest of the long-term strategic plan to archive this data. That committee also tackles any issues that come along with, any legal requests or, inability to retrieve data for whatever reason. So I feel that committee is so crucial with the work that I do, because they're the ones that, that if they approve something, then that trickles down throughout the organization that this is, everyone has signed off. We've all agreed this is the best path forward, and this is, the next project we're going to do. So that really works well in our organization.
Jim, any thoughts, advice, things you've seen work well in this area?
Yeah, I think back to Kory's comment about communication is key. As you approach these types of projects, key stakeholders usually are afraid. Especially clinical providers, their main concern is if you're asking what to migrate, as an example, to a go-forward application, they say everything, right? But usually that cost is prohibitive. But it's really born in a fear of, I want to make sure that my data is stable and reliable and present to provide care if it's clinical or, for other reasons. So getting and communicating early and often that a archive solution usually will provide all the data that they need for compliance, for e-discovery, for patient care, as an example, with significant demonstrations. So making sure that the vendor knows the source application and can demonstrate that capability, as an example, usually provides and has provided good results in terms of a comfort level to go forward with those, those teams that, as Tom's mentioning, around, the steering committee. But once you get down to that next level of actual users, as everybody knows, a lot of times they've used products for 15 years. It's hard to change is hard. So usually we find that early communication, over communication, as well as some of that demonstration capability has really helped kind of move those projects along, from the onset.
Very good. All right, next question, Kory, we're going to start with you. Talk about how to sunset applications and transfer data in a way that ensures data quality and security.
Well, obviously, if you're sunsetting an application, you're replacing it with something else, and so you're certainly not going to get rid of that application or the data until that other application is up and running and kind of burned in for a good period of time, probably 6 months, a year. We've certainly have had legacy systems that have kind of stuck around for multiple years, and so you end up just kind of keeping the lights on in terms of that sunset application, just because you may need to access it, you may need to extract it, or for various reasons because of the retention policy and the requests that you might get for information. And so, you know, you still have to include them in your backup procedures. You still need to include those in you know, your overall business continuity plan. And so those things aren't kind of, you know, sent offshore, if you will, or put out to pasture as soon as you've brought in a new application. You still need to manage that like you would any other solution that's an active solution for your users. So, you know, until you can get it archived into a solution that, you know, is all encompassing of all of your archive data that you're kind of built into your BCA and your backup plan, then you really have to treat it like a live active solution.
Very good, Tom.
Yeah, this is easier for smaller applications and obviously more difficult for large, you know, full-on EMRs. But you know, ensuring data quality is so crucial. I mean, we go through a very, very stringent validation process for every application we archive. So we keep the source application around, and when the archive is at the stage where we can test it and validate it, we have a full team on our end that goes in, brings out at least 10 to 20 patients and looks at every single piece of data that is in that patient record, compares it to the, you know, the data that was archived to ensure that everything was copied over, you know, and then our compliance team reviews that. And so there's a couple stages to ensure that the data quality of that sunset application is now retained in whatever new format and our application is now living. Security-wise, I mean, we definitely make sure that access to that data is only granted to whatever teams need it. Our focus is that we keep our archive data as primarily accessible by our HIM team. We don't necessarily give it always to like clinical office staff, even though they may have had access to that sunset application. They may not get access to the data going forward. We put a process in place where they will need to work with HIM to get whatever data requests. That is typically for older applications that you know, are not used as frequently. You know, a big EMR that we just archive, obviously we give, you know, those local staff access to the archive data. But again, like I said, we make sure that it is set up in a way where, you know, there is a process to get access and that data remains secure. It's not just wide open for any user to just go in and view.
Very good, Ed.
I think one point to emphasize there is the time required to validate the data, as was noted. You have to put that time in. And sometimes a static clinical system takes less time than an active AR. So if your organization is still running their accounts receivable and doing billing, to pick a time when users are locked out so you can do that comparison, that's important. And one thing to add to a previous question is the legacy vendors. You really need to look at what their longevity is going to be and their willingness or ability to negotiate. We had a situation, we had a 1-year contract with a legacy vendor and then wanted to go month to month, and the premium to do that was really cost prohibitive. So it accelerated our plan to do the archive.
Very good, Jim.
Yeah, and as the vendor who's performing the archival services, we try to build in a lot of, our goal is, as mentioned earlier, a lot of our projects for archival are kind of considered second or third tier against production systems. So we're already struggling to find subject matter experts, as an example, or folks that are assigned to other projects as their priority. So we take that very seriously. So we will do an automated level of testing. So things like record row counts, kind of normal activities around technology. But then we do a heavy set of similar verification, side-by-side comparisons. So much so that we want to get our projects done, completed in a timely fashion, that we built in a communication protocol into our application for submission of validation items that are found during that phase. So we've had the ability to, in some cases, shrink timelines from 2 to 6 weeks on average, just because of that back and forth, rather than dealing with phone calls, emails, spreadsheets, and such. So again, as well as, and then to shut these systems off, as everybody's mentioned, nobody's going to do that without some level of validation, which is important. And then kind of what we call verification, make sure that the sign off is complete before that system shut off and decommissioned. So take that very seriously. And then from the security standpoint, again, PHI is critical. So we, a couple of years ago, did a pretty significant investment in something called High Trust certification. So there's, gosh, over 400 control measures that we have to meet to make sure that as a vendor, we're good stewards of the data that we're archiving for our customers, amongst a lot of other technology to make sure that data is secure and provided as needed.
Excellent. All right, we're going to do our audience poll now, and I'm going to launch this poll. So it's a agree or disagree. Most health systems can reduce their application by portfolio by at least 20% without losing needed functionality. So what do you think? You agree with that, or you disagree? I was kicking around 25, and I went back to 20 because I wanted to be, really. 25 sounded like a lot, so I thought you'd get a lot of disagree. But 20% off the top, it's just bloat. What do you think? Agree or disagree? Our panelists can vote as well, so I encourage that. And then we'll take a look at that in a minute, and we'll have our panelists guess at that, which will be a lot of fun. So now I want to go to our Ask a Co-Panelist. So Jim, I want to give you an opportunity to ask your co-panelist a question.
Sure. Speaking back to the governance, what have you found as you go to decommission that system? Again, if you've got users that have utilized systems for a long time, what tips or tricks have you implemented to make sure that when it's time to sunset the application, there's not the kind of the hanger-on effect, right? We can't shut it down yet for X reason. What suggestions would you have for folks on the call here?
Ed, why don't you go first?
Yeah, I'll jump in. And really, your steering committee, your governance, they need to have the list of what they're charged with. And if this is one of them, they have to hold firm and really look at the ROI and not just personal preference. So if somebody has to present to a steering committee and they don't have a valid case, the committee needs to stand up and say, no, we're going to shut a system down and we're going to move forward. So it's sometimes people want to keep systems for convenience, and that's not a valid reason.
Mm-hmm.
Tom?
Yeah, I guess I haven't really encountered that. I think it was mentioned earlier in another question where we give an initial view of what the end result is going to be. So if you have users that are just so in love with this application that they've used for such a long time, and then they're worried that it's going to be this new complex system. But if you give a demo and say, okay, this is our goal. We want this data to be moved over, and this is what it's going to look like. Once you do that, they quickly do get on board, and it's not, it's not as painful of a process because the way, the way our archive data looks, it's very similar to the original application, and it's actually quite easier. So there's not that fear and pain about what the future is going to be, because they see it and they know it's going to make their life actually easier. So I don't experience that too much.
Yeah, if I can jump in, it sounds like Tom has a great process in place, and I think the fact they do demos and probably allow the end users to bring in, sample record and let's try this one, instead of taking a heavy-handed approach, is really get them comfortable with the archive. I think that's a great approach.
Yep.
Kory?
Yeah, heavy-handed, that's an interesting term. I would say that you can always draw lines in the sand, and we go through demos and we bring multiple product solutions for the same function to folks. And, ultimately when you're managing that portfolio, it's about, hey, we've got redundancies here. Where are we going to go? I mean, all this function lives over here in the EHR, but we've got these disparate systems. And so we want to kind of sunset those because we like a one patient, one record integrated kind of functionality. I would say, in the steering committee that we have, politically, they don't like to step in other people's sandboxes. So they're not going to make decisions about, okay, we're all going to vote and we're going to vote against you in your department so that you don't, they really shy away from that because they don't want the other folks to vote against them in their department on the decision. So I drive that decision based on cost, because I can get everybody on board with saying we don't need to continue to spend this money. And when we say we're going to migrate and we now need to archive, but I need them to get off of that system, it's usually a contract is ending. We're going to stop paying for support. And so if you're still on it past when we've paid support and it goes down, then you're out of luck and potentially data could be at risk. And so people get scared. I hate to use scare tactics sometimes, but when you kind of push them in that direction, then they kind of are forced to adopt and they're forced to move. And it's a lot easier to create those deadlines.
If I could add
Very
one point
good.
to what Kory
Go
said,
ahead,
just a second, is bring in those managers in those departments to help you in discussions with the vendors. These vendors that are going away, there's a lot of reasons for that. And those vendors' willingness and ability to keep systems running gets less and less over time. So, bringing them in so they can see firsthand the vendor's ability or inability to keep a system running and keep it running at a cost effective, because those vendors many times are not able to do that.
All right, I want to go to our, actually I want to get an audience question in here. So let me get to that. How much of your archive solution is on premise versus in the cloud? Do you see there's a strong value proposition moving archive to the cloud? Ed, let's start with you.
Definitely, our archive is in the cloud, and it really then reduces that need for the in-house maintenance, support, licensing, et cetera. So definitely in the cloud.
Tom?
Yeah, we're actually 100% on premise. So I'm very curious about the answers of the other panelists on this question, because that's the way we've set it up. And I know some people on our side are wondering if it would be worth it to actually move to the cloud. It doesn't take too much work on our end to maintain our current environment. So it's not like we have a full-time, technical team that's working to keep that up and running. So it's not a lot of work on our end. I think initially they like the thought that our data is here and we have control over it. And, back 6 years ago, the cloud was a little scary, and I think it's not as, that way anymore. But we are 100% on premise, but definitely open to, exploring the remote and cloud hosted in the future.
Kory?
Yeah, no, I would agree with Tom. We're totally on premise. We're a mid-sized organization, and so we're not. Again, I think when you move a lot of things to the cloud, there's a lot of expense, associated with that. Right now, we have not found the magic price point, and it's still more expensive for us to be in the cloud than it is to be on premise, given kind of what we do elsewhere with the rest of our technology. So yeah, we're still on prem.
Jim, any comments there?
Yeah, like I mentioned earlier, it was definitely that way when Tom and Kory became clients of ours quite a few years ago. Oddly enough, over the last couple of years, primarily, I'd tell you that about 80 to 90% of our customers choose the hosted option. So certainly would like to talk with your teams. And I think the price points have come down from the earlier points to make that more economical. There's definitely benefits from a maintenance perspective as well in the cloud. We've moved a lot of our solution to microservices. So if you upgrade one item, it upgrades all who's in the remotely hosted environment, as an example, versus cab processes and individual, customer related downtime for upgrades and things like that as well. But again, the offering is still available, both on premise as well as hosted, because we've got a lot of customers that feel the same way as Kory and Tom and their teams. So it's really a customer, driven activity or decision.
Great. Next audience question. I would like to hear what the panel experience has been with clinical imaging archiving and reducing portfolios such as multiple PACS systems. Jim, why don't we start with you? Any thoughts?
Yeah, certainly. What we find typically is most folks are migrating those PACS solutions to their go-forward solution, and we'll archive the reporting aspect as well as provide a hyperlink to where those images reside. I think that's changing. There's a big push for just general VNA independent solutions. So we've been asked to basically kind of retire those systems or archive those systems and bring that into our product offering as well. And I think over the last 12 months, we've seen that more often than we have in the last, 4 or 5 years.
Tom?
Yeah, I think the biggest obstacle with that is to make sure that whatever solution you're migrating from has the ability to extract those images in a standard format like a PDF. We've done it and not have any issues, but we definitely always, before we actually commit to a project, we just want to work with the existing vendor to make sure they're able to get those images out and they're in a format that can be archived. It's a little trickier when you're dealing with PACS images, but typically we haven't had any issue getting them in the format we need.
Ed?
My experience is about 4 years ago converting from one PACS to another, and we did convert those images. It took a fair amount of time and expense. So making sure everyone plans for that is important. With cardiology images, there's so many different types, and we had different experience and different success in converting cardiology images.
Kory?
We're actually going to do that this year. We're actually going to move to an enterprise imaging platform that combines both radiology and cardiology imaging. There's so much integration with our EHR that we're not going to archive them. They're going to be kind of migrated to a VNA, which is still integrated with the EHR and still tied to all the historical encounter reporting data. So not really something that I think is typical to just put all that data into an archive. I think it's certainly possible, but most facilities are probably going in a VNA type direction.
All right, very good. We're going to look at the results of our audience poll. And as I said, I'm going to get our esteemed panelists to guess. I want percentage agree. What percentage agree with the statement that you can reduce the portfolio by at least 20% without really feeling any pain? Ed?
I think 50%.
50%. Tom?
I'd go a little higher, maybe 60.
60. Kory?
Number that immediately came in my head was 57.
57. Jim?
Wow, I had 40 in my head.
40. Wow, he's going on the low end here. Well, the answer is 96%. 96%.
Wow.
Everybody thinks there's lots of bloat out there.
Yeah.
Wow. So the winner there is going to be Tom at 60. Well done, Tom. Well done. All right. We're getting close to the end of our time here. I want to give Jim an opportunity for a last word of advice to our IT executives on the line. We had a couple of good questions from provider side IT executives asking questions. Obviously, people are grappling with this. The two questions I asked are someone's dealing with them right now. So, Jim, your final words of advice.
Yeah, I think the three panelists certainly have put us through the paces when they made their decision early. As with any significant purchase or outlay in such important decisions, I would stress to folks listening that the search process is important. Making sure that a archival vendor of choice has the breadth and the depth and experience to get through their entire portfolio. Last thing, we see a lot of pickups in terms of clients, in terms of they've gotten through one or two, but can't get through the entire portfolio. So it's, like I said, it's a big decision. And again, you don't want to find yourself with archiving of archives, if you will, and have another bloat issue as you go down, down the path to make your decision.
Excellent. All right, that's about all we had time for today regarding continuing education. You could use the final slide in this deck. You'll get an email when the on-demand recording of this event is ready. If you want to sponsor an event with us, you can reach out to Nancy Wilcox from our team, and you can go to our website to register for upcoming events. With that, I want to thank our excellent panel, Ed Duryee, Kory Hudson, Tom Branigan, and Jim Hammer. I want to thank Harmony Healthcare IT for making the discussion possible, and I want to thank you for attending our events. And with that, everybody have a wonderful day. Thank you.
Thanks,